I figured the most good that I could do if I came here to speak to a European audience would be to correct some of the misimpressions about the U.S. health sector. There are a lot of misunderstandings about the U.S. health sector in the United States and in Europe. And what I want to do is I want to draw from two recent books, Cato books, to which I contributed. This one I wrote, and this one I contributed a chapter. They both have information that is, while they focus mostly on a U.S. audience, they both contain information that would be of interest to any European who wants to understand not only how the United States health sector is different from the perception of most Europeans, but how similar it is to many of the health systems here in Europe. So, without any further ado, I just want to give you a brief overview of what I'm going to be discussing tonight. First, I'm going to introduce myself, talk about two principles that guide my work. Related to one of them, I'm going to talk about how free markets, if what you want is universal health care, what you need is free markets, because free markets, more than any other system, make healthcare more universal. I want to talk a little bit about this idea that most people have of the U.S. health sector, that it is a free market, and then explain or give some reasons why the United States may be even less of a free market than many of the other health systems you know and may or may not love. I'm going to explore a little bit the question of which nation has the freest healthcare market. This is in the 28 years that I've been doing health policy, this is the question I get more often than any other, so we'll have a look into that. And then I want to give a libertarian audience some reason for optimism about reform in the United States and reforms that you can also apply to your health systems. By way of introduction, if people in this world know me for anything, it's for the role I played in some efforts to try to block and get Congress to repeal the Affordable Care Act, or what people have come to call Obamacare. I wasn't successful in that effort yet, but I'm committed to repealing those laws, or at least giving consumers an alternative around these regulations that you will find in Obamacare for reasons that will become evident. About those two principles, I say, that guide my work at the Cato Institute. I talk about these in my latest book, Recovery. And those two principles are basically this. When it comes to healthcare, we do have rights. When people ask me, do we have a right to healthcare? My answer is yes, we have not just one right, we have many rights when it comes to our healthcare. The most important being the right to make our own health decisions. And when governments respect that right, what ends up happening is free markets make healthcare more affordable, they improve the quality of medical care, they make access more secure, and they make healthcare more universal. Why do I say that? Because in the United States, I'll be giving more of an overview of the United States in a moment, but in the United States, there are corners of the health sector where you do see market forces breaking through and affecting some change, and they usually don't scale, and then government usually crushes them. But they show remarkable progress. This is an example. This chart is an example. What you've got there is a number of medical technologies, and what the graph shows is the results of a series of experiments, not one discrete experiment, but multiple experiments that a private insurance company launched to try to overcome some of the perverse incentives the government introduced into the market for health insurance, and take advantage of market mechanisms to see if those market mechanisms would drive down prices. The results were consistent and they were dramatic. When the insurance companies deployed these innovative plan designs, what happened was they made their consumers more price conscious, not so price conscious that anyone went without medical care. Everybody got all the lab tests and all the arthroscopies and all the hip and knee replacements that they wanted. But by making the consumers price conscious, those prices fell dramatically. Prices for hip and knee replacements at the high price hospitals in California fell by 37% over a two-year period. When do you ever hear about those sorts of price reductions in healthcare? You hear about them when consumers control the money and are price sensitive and change their behavior based on price. And if what you want is universal healthcare, then these sorts of outcomes should be your obsession. Policies that drive prices down, bring healthcare within the reach of more people, and make it easier for the rest of us to provide medical care to those who still cannot afford it. The ever-shrinking number of people who still cannot afford it themselves. Unfortunately, these experiments that the insurers launched are experiments that the government penalizes, so they don't scale. But there are other innovations that take place in the US health sector. Despite government's best efforts to crush plans like Kaiser Permanente survives. It is an integrated health system. Think of it as a private sector version of the British National Health Service, where the health insurance plan and the hospitals and the doctors all fall under the same corporate entity. With that sort of a structure, that sort of innovative structure, there's nothing else like it in the United States, except for one government run plan I'll tell you about in a moment. With that sort of a structure, these plans face unique incentives to use electronic medical records to make healthcare more convenient. And they began deploying electronic medical records, not when the government began requiring healthcare providers to do it in the 2000s, but in the 1960s, before even I was born. Kaiser Permanente began using electronic medical records, and by the time the drug Vioxx came onto the market, does anyone here remember Vioxx? I know one person who does. Vioxx was a painkiller that ended up, it turned out, caused adverse cardiac events. It caused heart attacks, and it killed people. But the US Food and Drug Administration approved it anyway. And you know who was able to identify those deadly side effects of this painkiller? It was Kaiser Permanente with their electronic medical records. They did a better job of identifying an unsafe drug than the US Food and Drug Administration did. And they use those records to do other research that improves the quality of medical care and improves convenience for patients. But government has been blocking and penalizing these sorts of plans for about 100 years. Health insurance. What else are markets doing in health insurance? Well, when you free health insurers from government regulation, what this chart shows is that the premiums for comprehensive health insurance are much, much lower than when the government slaps all those regulations on them. The blue dots here show the lowest priced Obamacare or Affordable Care Act plan available to a 64-year-old female in all of those cities across the United States. And the orange bars show the range of premiums for plans that are exempt from those regulations. You can see that you can buy more coverage than Obamacare offers if you want. But you can also buy much more affordable comprehensive coverage. According to the Congressional Budget Office, they cost 60% less than the lowest cost Obamacare plan. This is something we should be cheering. This is something we should be encouraging. This brings healthcare within the reach of people who otherwise would not be able to afford it themselves. But the Biden administration recently moved to cripple those plans, make them less comprehensive so that no one would want to enroll in them. What this graph shows, I have an entire presentation where I use a whiteboard and give a whole econ presentation about the innovations that this graph highlights. But the short version is that the blue bars represent the probability of losing your health insurance after 1 year if you're in a plan with very little government regulation. The orange and gray bars show your probability of losing health insurance after 1 year if you're a 28-year-old male in poor health. If you are in an employer-sponsored plan, either a large one, the gray bars, or a small employer plan, the orange bars. And what it shows is that the markets are doing as good or better a job at making healthcare secure, access to care secure for the sick, than the health plans that the government has been favoring, the employer-sponsored plans. And not only that, what this graph doesn't show is that the relatively free sector of the health insurance market developed innovative products that filled in the gaps in the employer-sponsored system the government favored, so that when people lost their jobs, they wouldn't lose their health insurance protection. But the government then outlawed those plans as well and blocked all of those and further innovations that they would have developed that would have made access to care even more secure for the sick. Now, you've all heard some version of this claim that the United States health sector is one of the only developed countries, the Economist tells us, where healthcare is left mostly to the free market. And there is some basis for this claim that you don't just make it up out of thin air. But there is something sort of unsettling about this claim. If the United States, these are data that show the lobbying expenditures by various sectors of the US economy, how much those sectors spend to lobby the federal government. It turns out that the health sector has outspent every other sector of the economy in terms of federal lobbying for the last 20 years. They spend far more than the second place and 6 times more than the defense industry. You've heard of the US military, perhaps? It's kind of big. It makes a lot of people very wealthy, a lot of defense contractors, and then they plow some of that wealth back into lobbying the US Congress in order to expand the US military further, get it to buy new weapons and hire more people and build new planes and ships and that sort of thing. They spend a lot of money to lobby Congress, but the health sector spends almost 6 times as much, bless you, to lobby Congress. Why is that if the US health sector is a free market? Why is why is the healthcare industry spending so much money to lobby Congress? Is it to keep the US health sector a free market? Or is there something else going on? We might think that that the US has a free market if we look only at the tax burden of the federal tax burden in the United States, which is about 25% of GDP, lower than the OECD average and much lower than Denmark, which is at 45%. We might also think the US has a relatively free market if we looked only at private health spending, which plays a larger role in the US health sector than in other nations' health sectors. You can see that other advanced nations' private health spending comprises a much smaller share of overall health spending in all other advanced nations, perhaps except for Switzerland. But more about Switzerland in a moment. And if you conclude from that the US does have a relatively free health sector, well, then it might be reasonable to blame the fact that, or at least part of the fact that the United States has higher prices for healthcare than most nations, 43% higher than the OECD average, according to the OECD, or that free markets lead people to consume more medical care than more government-dominated systems, 49% more than the OECD average, according to the OECD. And you might conclude that you might combine those two numbers together, and maybe free markets are responsible for the fact that the United States spends more than twice per capita as the average OECD nation, and about, 70% more than as a share of GDP than the average OECD nation. Far and away, the largest share of GDP among OECD nations at 16.6% is how much we spend on healthcare in the United States. All the result of free markets? Well, before I get to that, and you might also, that might also lead you to blame free markets for the apparently poor health outcomes that we see in the United States. On the figure on the left, what that shows is on the x-axis, the level of per capita or health expenditure in the United States, and I believe it is per capita health expenditure relative to the OECD average, about 2.5 times the OECD average, and the y-axis shows life expectancy relative to the OECD average. You want to be above that blue horizontal line. The United States is on the wrong side of that horizontal line. Health, and it's spending an awful lot of money to have such poor life expectancy. On the second panel, you want to be below the horizontal line because that is avoidable mortality that is amenable to medical treatment or preventable through non-medical interventions. Again, the United States is spending an awful lot of money to be on the wrong side of that line. So if the United States is a free market system, it might be reasonable to blame free markets for that outcome. But is the United States a free market system? I submit to you that not only is the United States not a free market, not only does the United States already have socialized medicine, it has every form of socialized medicine known to man, and known to other nations, and even at least one form of socialized medicine that no other nation has. More than half of the U.S. population, here it says 48%, but that it's actually more than half of the U.S. population has health insurance through an employer, not unlike the compulsory health insurance through an employer, not unlike the German system of compulsory employer-sponsored health insurance. The United States has its own version of the Canadian Medicare program. The Canadian Medicare program and the U.S. Medicaid program are both programs where the national government sends a bunch of money and a bunch of rules out to the provinces, in the case of Canada, or the states in the case of the U.S. Those provinces and states then operate a universal health program for a certain population of people. In Canada, it is the entire population. In the United States, it's about 70 million people who are generally low income. So we have our own version of the Canadian health system. We even have our own version of the British National Health Service. I mentioned before that Kaiser Permanente is like a private sector version of the British National Health Service. Well, we have a government sector version of the British National Health Service, the Veterans Health Administration, which covers about 1% of the US population that is veterans of the US military. And it again is a system where the payer and the provider of healthcare are all part of one entity. The federal government owns the hospitals, employs the physicians in the Veterans Health Administration, and of course finances 100% of the medical care, just as in the British National Health Service. In what we call the individual market in the United States, where people buy health insurance directly from insurance companies, we have now, for the past 10 years, a system of managed competition not unlike what you find in Switzerland and Netherlands and other European countries, and even to some extent in Slovakia, where I was this morning. That covers about 10 million people or so. So we have that form of socialized medicine as well. We have an innovative form of socialized medicine that no other country has been able to replicate. The US Medicare program covers 66 million people at a cost of about $1 trillion. In terms of dollars spent, it is the largest purchaser of medical services in the world. It is a program run entirely by the national government, covering a massive number of people sprawled out over a very large nation and continent, where it sets the prices and for billions of services across that vast geography and that vast population of patients. And as I say, no other country in the world has been able to match it. We then have an additional share of the population, about, 3%? 3.5% of the population who are enrolled in both our version of the Canadian system and our own Medicare program. We call them dual eligibles. And then finally, we have what may be a relatively unique feature of the US health sector. We have about 8% of the population that has no formal health insurance. Now, it is true that in a free market, some people will not have health insurance. Is that why we have 8% of the people in the 8% of the US population that has no health insurance? Not exactly. What's happening here is all of those other government interventions have done so much to drive up the price of health insurance, drive up prices for medical care, that many millions of Americans feel that they cannot afford it and therefore choose not to purchase it, and perhaps figure they will rely on the implicit government guarantees of access to care that all of those other programs provide, should they need to fall back on that option. The uninsured population in the United States, in my estimation, is larger than it would otherwise be because of all of these other government interventions. And if you look across the US health sector, what you see is not only does the United States not have a free market, but we have every form of socialized medicine anyone has ever devised. I like to say that the greatest trick that advocates of socialized medicine ever played was to convince the world that the United States does not already have it. How much control do all of those interventions give government over the US health sector? I've already shown you lots of data from the OECD. You've probably seen those data before about per capita, and as a share of GDP and so forth. The The OECD also collects one measure of health spending that doesn't get nearly the attention as the other figures I just showed you. The OECD measures how much of a nation's health spending is voluntary versus compulsory. In other words, how much of a nation's health spending do the consumers get to spend according to their own wishes without the government pushing them one way or another, penalizing them unless they spend it the way the government wants, and how much of that spending is compulsory. Compulsory spending can either be taxes that go to fund government programs. Obviously, taxes are compulsory, but it also includes private spending that you either have to spend the way the government wants or the government will penalize you. There are lots of European systems with compulsory private spending, and in the United States, employer-sponsored insurance is compulsory for reasons I'm happy to explain. And what the OECD finds is, when it looks at compulsory versus voluntary health spending, it finds that the United States ranks rather high in terms of compulsory spending. 85% of health spending in the United States, the OECD tells us, is compulsory. That is just 2 percentage points shy of Germany, which ranks first in terms of compulsory health spending at 87%. It puts the United States in a statistical dead heat with France, Czechia, Denmark, and Norway, which all have socialized systems, is what I keep hearing. And yet government in the United States has as much control over health spending in the United States as those nations' governments do in those socialized systems. This is curious. It is also curious that government in the United States controls a larger share of health spending than government in the United Kingdom, or in Slovakia, or in Austria, Poland, or in Canada. Remember, in the UK and in Canada, you have fully socialized systems where people don't pay anything out of pocket, and the government provides a guaranteed access to universal health care for all, and still the governments there don't control as large a share of spending as they do in the United States. This is curious. It means that these interventions are giving government in the United States a tremendous amount of control over the health sector. What does it do with all of that control? Well, as I explain in my chapter in Ryan Bourne's new book, The War on Prices, I encourage you all to pick up a copy and read every chapter, but particularly the healthcare chapter. As I explain in the healthcare chapter, it gives government the power to set most of the prices in the health sector. Is this a free market? Hardly. What else does the government do with all of that power? Well, it encourages people to enroll. It either subsidizes more comprehensive health insurance than people would choose for themselves, or it penalizes people unless they choose more comprehensive coverage than they would choose in a free market. That means that the US population is more heavily insured than it would be in a free market. And all of these government interventions are driving down the share of spending that comes directly from the patient and goes directly from the patient to the consumer. The share of health spending that is out of pocket in the United States is a smaller share of health spending than in the vast majority of other advanced nations. Only a few nations it's about 11% in the United States. In only a few nations is the out-of-pocket share of spending lower, like France and a couple others. That is a lower percentage of health spending that consumers are paying for themselves than in the fully socialized British and Canadian systems. Again, more evidence that maybe the conventional wisdom about the United States being a free market is missing something. This graph shows what has happened to the out-of-pocket share of health spending in the United States since before the federal government enacted the Medicare and Medicaid programs in 1965 and since. Now, before 1965, the government was already intervening heavily by making employer-sponsored insurance compulsory and penalizing people unless they purchase more comprehensive coverage. So the share of out-of-pocket spending was already falling as more and more people were purchasing more and more comprehensive health insurance. It continued to fall when the government created the Medicare and Medicaid programs, and you had all of those interventions operating at the same time. And then as government expanded those programs and created more programs like the Children's Health Insurance Program, Obamacare, and so forth, you see the out-of-pocket share basically plateauing in the past decade or so, but still falling. It's now about 11%. What has happened to healthcare prices over that period? Well, as economists will tell you, economists of both the left and the right, the more heavily insured people are, the less they will shop around on the basis of price, because the savings go to someone else. They go to the government, they go to a private insurance company, maybe their employer, it seems. And so what is and healthcare providers have gotten the message. What the other two lines here show, the blue line and the orange line, show the price indices for medical services and medical goods over that same period, over and above inflation. If medical prices only rose at the same rate of inflation over this period, those two lines would be flat along the x-axis. Instead, they have risen dramatically over that period. By the same token, per capita health spending has risen dramatically as consumer price sensitivity has fallen, showing that people will also purchase a greater volume of services when the government insulates them from the cost of those services. And while that wasn't direct evidence, this is just correlation, okay? It's obviously not causation. There's more direct evidence in what happens when government imposes regulations that require consumers to purchase health insurance that covers certain goods at 100%. The Affordable Care Act, or Obamacare, which Congress passed in 2010, began to phase in in 2011 began to phase in a regulation that required consumers to purchase health insurance that covered all prescription contraceptives at 100%. Prior to that, there was cost sharing for these drugs, and what you saw with in the prices of these drugs was they were falling relative to inflation. They were at least holding steady, but in many years falling relative to inflation. So they were becoming more and more affordable over time. Obamacare's regulation reversed that trend. When it began taking effect, and especially after it took full effect, the prices for hormones and oral contraceptives began to skyrocket. I submit the reason is, while this again is not causation, necessarily causation, we're getting closer. What happened here was that the manufacturers of these products realized that when their customers are fully insured from the prices of their products, they're not going to switch from the contraceptives they like to another contraceptive. So if the insurance company tries to negotiate a lower price by excluding this product from their formulary, their enrollees are going to rebel, maybe force their employer to switch to a plan that does cover that drug. And so the providers got that message and they began jacking up their prices. And the graph that I showed at the beginning that showed that prices were falling for hip and knee replacements and shoulder arthroscopy and lab tests and CT scans and MRI scans and so forth, further evidence, I think even more direct evidence, that insurance and reducing price sensitivity among consumers increases prices. Another thing, though, that is happening as a result of all of this government control of healthcare and government flooding the health sector with subsidies and the outrageously high prices for pharmaceuticals and other items that result is that the United States has been a powerhouse of medical innovation, creating new diagnostic tests and treatments and even cures for once incurable diseases like hepatitis C. This is the molecule sofosbuvir. This is the drug that Merck turned that molecule into, Sovaldi. It's a 95% cure for hepatitis C, a previously incurable disease. It reduces all-cause mortality among hepatitis C patients by a whopping 50%. This is a miracle drug. And it came from the United States. Researchers in the United States developed it. Drug companies in the United States marketed it. And remember these graphs that I showed you before and how poorly the United States is doing and how much better European nations are doing on both of these graphs? I think it's important to keep it in mind when we make these international comparisons that part of the reason why those European nations are doing so well is because breakthroughs like Sovaldi and lesser but still important medical innovations don't remain in the United States once the United States develops them. They disseminate around the world and they improve health outcomes even in European and other supposedly universal health systems, those health systems get the credit for the lives that those U.S. innovations save, and the United States gets dinged because for all the money that it spends developing and creating the incentives to develop those innovations. So keep that dynamic in mind whenever you hear about these international comparisons that show that obviously the United States health sector is less efficient, less dynamic, and worse than other nations. I think it's highly unclear. There's a lot of things that confound those comparisons. Final OECD measure, we talked about how much control all of these government interventions give just over healthcare spending in the United States, the direct controls over health spending, and how health spending accounts for 85, or government or compulsory health spending accounts for 85% of health spending in the United States. If we then map that onto the share of GDP that healthcare consumes and how much of US GDP is voluntary versus compulsory spending, what we find is it's about that, as we mentioned before, about healthcare consumes about 16.6% of GDP in the United States, and only a small share of that, a couple percentage points of that, is voluntary health spending. But 14 percentage points of GDP is compulsory health spending. What is remarkable about that figure? It means that compulsory health spending in the United States exceeds total health, as a share of GDP, exceeds total health spending in every other OECD nation. So whenever anyone asks, why is it that the US health sector spends such a large share of GDP, or the United States spends such a large share of GDP on healthcare, the answer is because government compels us to. It's not a result of market forces, it's a result of government. So now to address that question, so by some measures, the United States might have even less of a free market than other nations do, because in many nations, more of the spending is voluntary than in the United States. The government requires you or taxes you less to support a government-run health sector than the government in the United States does. And there are other measures of individual freedom or how much a nation uses market mechanisms to allocate healthcare resources on which the United States looks rather poor. So in 2009, the US government did a study, looked at 86 different pharmaceuticals and asked what kind of barrier to governments in these 5 countries, Australia, the United Kingdom, the United States, Italy, and Netherlands, what kind of regulatory barriers do these nations put in the way of patients' ability to access those medicines? And it turns out that the United States puts as many barriers in the way of patients' ability to select these drugs and self-administer these drugs as Italy and the Netherlands does. About, 51% versus 50% or 48% in Italy and Netherlands. 50% of the time, these nations are requiring consumers to get permission from a government-appointed gatekeeper before they can access these medicines. What am I talking about? Permission from a government-appointed gatekeeper. You know these regulations and those permission slips as prescriptions. In most advanced countries, it is the government that decides what drugs consumers must get a prescription in order to purchase, which means that the more the more drugs the government subjects to these prescription requirements, the less freedom consumers have to make the choice themselves about what medicines they will take. But in Australia and the United Kingdom, it's different. Patients there have more freedom to go and select and purchase those 86 drugs than they do in the United States. Again, these are nations with socialized systems where supposedly they have less freedom than in the free market paradise of the US health sector. And yet by this measure, they have more freedom than in the United States. Another one that I find particularly glaring and galling is that in 100 countries around the world, women can purchase daily use oral contraceptives, the pill, without a prescription. but not in the United States. Or you'll notice in most of Western Europe, Australia, some Southern African countries, and Saudi Arabia. In those countries, the government requires women to obtain a prescription. So women have less freedom to make this decision for themselves than in most countries in the world. And this is for a drug whose risk profile is well known and well established. It has been on the market for 60 years. Women know how to self-administer this medication. They know when to seek advice. There have been studies that show that when women are self-administering the pill, they're actually more conservative than the recommendations that physicians make when they prescribe this drug to women. There's no justification for preserving those prescription requirements. But again, the point here is that women in the United States have less freedom than women in many other countries in the world to purchase those medications. And finally, just in case you thought that, well, all right, the problem though is that while the government might have a lot of control, it doesn't have enough control over the US health sector. What it needs is, we need more government. We need to move more people into, say, the US Medicare program, which is more efficient than private health insurance, isn't it? It pays lower prices anyway. Move more people into the US Medicare program in a Bernie Sanders-style Medicare for all system that will finally contain healthcare spending in the United States and bring it in line with other advanced nations. A recent study in the Journal of the American Medical Association cast doubt on that hypothesis. It measured health spending in the United States by age group to health spending, the average health spending in those age groups across 7 different countries. And what it found was, for all age groups, the first orange bar right here, for all age groups, the United States spends about 70% more across the board than the average of those other nations. But what happens when you look just at the Medicare population, the elderly in the United States and the elderly in those other 7 nations? Well, it turns out that health spending on the elderly in the United States is even higher, 80% more than what those other nations spend. So Medicare is even more out of line with international norms or norms in advanced nations about health spend when it comes to health spending than the rest of the US health sector. Moving the rest of the US population into a Medicare type program is not going to reduce healthcare spending in the United States. If the data are any indicator, it will increase healthcare spending relative to other nations. So we've got this mess of a US health sector. What else? We've got all these interventions on the spending side, on the demand side for healthcare. What is the government doing on the supply side? Well, it's doing all sorts of things to interfere with market entry and interfere with the its ability to use the division of labor to make healthcare more affordable. Every state in the union regulates clinicians, which means if you want to practice medicine as a doctor or as a nurse practitioner, as a nurse, as a dentist, a dental therapist, or a dental hygienist, you have to get permission from that state and every state in which you want to see patients. And some states don't even recognize some clinician categories. So if you get a license from a dental therapist in Washington State or Oregon, over here on the West Coast, that's great. You've been through dental therapist school and you've got your license, but you cannot go set up shop in California because California completely prohibits dental therapists from practicing, as do most states in the union. Interfering with the right of individuals to choose dental therapists and interfering with the free market's ability to, with free entry into the market and the market's ability to harness the division of labor to the benefit of patients. Dental therapists make extractions and fillings more affordable than when dentists provide them because they don't have the student loan burden that dentists have, so they can charge lower prices. Those same regulations also block Kaiser Permanente and other health and other similar integrated plans, which innovators are still trying to develop and launch in the United States. They block them from taking hold and from expanding, depriving consumers of the benefits of these plans that I've already discussed and further benefits. I want to introduce you now to some of the victims of those regulations. On our left, we see Shelley Horowitz. She's a hemophiliac patient in Northern California. On our right, we have Emory University student Helen Curry. Remember, Shelley lives in Northern California. Helen Curry lives in Georgia, in Atlanta, which is the capital of, in Georgia on the East Coast. That's important because Shelley lives here in Northern California. To see her specialists up in Oregon, they would be happy, which is the one state north. They would be happy to see her via telemedicine. Just get on the internet and have their consultations that way. Or even on the phone, they would be happy to do that. But the state of California prohibits that. Why? Because those doctors don't have a license from the state of California. They are the top specialists that she can find in the field of medicine that treats hemophilia, and yet she cannot just get on her laptop and talk to them via Zoom. So Shelley Horowitz has to drive 600 kilometers from her home in Northern California all the way up to Portland, Oregon, just to see her doctors. She's actually relatively lucky compared to Helen Curry. Helen Curry, student at Emory University, lives in Atlanta, Georgia, right about here. To participate in the treatment program, she wanted to join in Boston, Massachusetts, way up here. She would love to do it via telehealth. It was a telehealth program. But because her doctors did not have a license in the state of Georgia, or in the state of South Carolina, or North Carolina, or Virginia, or Maryland, or Pennsylvania, New Jersey, New York, Connecticut, or Rhode Island, she had to drive 1,600 kilometers from Georgia all the way up to Massachusetts, rent a hotel room, just so she could sit in a hotel room in Massachusetts and open her laptop and see her doctors. These are ridiculous barriers to entry into healthcare markets. They are doing nothing to improve the quality of care. They are just increasing the cost of care to the detriment of patients like Shelley and Helen, who had the means to overcome those barriers. Most patients do not. Those innovations like telehealth and other innovations I've mentioned could be making healthcare more universal. Government regulation is stopping them. Now, home stretch, okay? Reasons for optimism. In the United States, there has been a movement to try to tear down some of those barriers to entry into healthcare markets, to tear down the barriers to telehealth. These states have implemented licensing reforms that recognize some occupational licenses from other states. Not all occupational licenses, not all of them apply to healthcare. I live over here in the Commonwealth of Virginia. Our occupational licensing reforms, the recognition of licensing from other states, does not apply to healthcare providers. But there has been movement along these lines. In Arizona, their reform does apply to healthcare providers. And there have been discrete telehealth reforms in some states that have torn down some of those barriers. While the Biden administration has moved to block these health insurance plans that are exempt from federal regulation, that make healthcare, that make health access to care more secure, more affordable, and more secure for the sick, and more affordable and more secure, the Biden administration has blocked them, depriving patients like Colette Briggs of those sorts of health plans. Colette Briggs had a health plan one of these types of health plans, okay? A pre-Obamacare individual market health plan. If the government had just left her alone, she would have had a much easier time finding the care that she needed when she received a leukemia diagnosis at age 3. But shortly after, or was it shortly before that diagnosis, Obamacare threw her out of her more secure health plan and into an Obamacare plan that penalizes insurers if they provide high quality care, into an Obamacare plan that operates under regulations that penalize insurers if they provide quality care to the sick. So Colette's family had to scramble to find a health plan that would cover the hospital and the oncologists that Colette needed. They had to call their senator, meet with their senator, get their senator to harangue the insurance companies, because every time they enrolled in a plan that would cover Colette's care, that plan would drop the hospital or drop the oncology practice midway through the year, leaving her high and dry. Thank God her father was in PR, because he knew how to work the political system to get a senator to harangue a health insurance company to let that physician practice or let that hospital back into their network. But not every cancer patient has a father like Christopher Briggs. And lest you think I'm just picking an anecdote out of thin air, President Joe Biden's economic advisor, Michael Caruso, has admitted that this dynamic takes hold because of Obamacare's regulations, and despite all the efforts by all the king's horses and all the king's men to counteract this perverse unintended consequence. And so I said I was going to give reason for hope. There is one last reason for hope for health insurance in the United States, which is that the Obama administration itself exempted U.S. territories like Puerto Rico, Guam, the Northern Marianas Islands, the U.S. Virgin Islands, and exempted those U.S. territories from Obamacare's expensive regulations that led to the problems that Colette Briggs was facing. Every state in the union can therefore free their employers and their consumers from these oppressive regulations by recognizing health insurance licenses that the U.S. Virgin Islands issues. And for that matter, every state in Europe could do the same. If they just said we will recognize as a valid product in our polity, notwithstanding any other provision of law, any health insurance plan that issues from the U.S. Virgin Islands. Similarly, in the United States, there's a tremendous opportunity to reform the Medicare program, because the Medicare program in the United States has a lot in common with the Slovak system where I just was, and some other systems in Europe, where you have a government-run plan that is basically competing with private insurers who operate under some of the regulations that were hurting Colette Briggs and others. And in order to overcome those harms, the government provides additional subsidies to cover patients like Colette Briggs. The subsidies are never quite right, so those perverse incentives to the penalties on quality care still exist. But the opportunity here is the same in the U.S. Medicare program as in the Slovak health system and other health systems around the world, where you have the government providing risk-adjusted payments to health insurance companies to offset the perverse consequences of regulations harming the sick. You could just take those risk-adjusted payments where the hemophiliacs the insurers get a larger payment for a hemophiliac than for a healthy patient. Take that amount, that hemophiliac premium, give it to the patient. Let them choose their health plan. You don't even have to fear market-based premiums, actuarially fair premiums based on risk, because the government will be subsidizing patients enough that they will be able to afford those premiums. And what will happen then is we'll see the sorts of high-quality, low-cost health plans that Colette Briggs had before Obamacare, and that could be making health care, access to care, more secure today. Final reason for optimism is, I mentioned that in the United States we have compulsory employer-sponsored health insurance. That system allows U.S. employers to control $1 trillion of their workers' earnings every year and use it to choose and purchase their health insurance plan. And if I haven't emphasized this, it is lousy health insurance. Every single employer-sponsored plan in the United States is lousy, low-quality health insurance. Why? Because it disappears for no good reason. It disappears when you change jobs, and no health insurance plan should do that. But that's what the government compels people to buy, and a system under which the government compels workers to let employers control $1 trillion of their earnings. But the government has also created what we call tax-free health savings accounts that let workers reclaim just a tiny sliver of that money that their employers were controlling, about 4% of that $1 trillion per year. And by building on health savings accounts in the United States, the federal government can reclaim for workers control over that $1 trillion, give them a vehicle where they can take hold of that $1 trillion and begin spending that money better than their employers did in a price-conscious way that will drive down prices and make health care more universal in the United States. Because if I haven't mentioned this before, if what you care about is universal health care, then this chart should be your obsession. getting prices down to the lowest level consistent with whatever level of quality the consumer wants should be your obsession, because that is how we make everything more universal. That is how we have made food more universal, so universal that we are able to keep 8 billion people alive on the planet right now, a feat that humans have never accomplished before. It's partly because of pharmaceutical innovations that have vaccinated people against disease and so forth. But I think even more so, it's the result of innovations in food production and distribution that have caused the price of food to plummet so that we can just feed more and more people. We need the same sort of revolution in healthcare, driving prices down, because that is how you get to universality. And all the data show that the way to do that is by respecting those two principles that I mentioned at the beginning, that people have a right to make their own health decisions, which means controlling the money controlling their earnings and spending those earnings according to their preferences. And once you do that, once you respect that right, markets will naturally make healthcare more universal. So with that, I want to thank SFL, the Austrian Economics Center, the Cato Institute again. I'm happy to stay here and answer as many questions as you all have. Thank you very much for your patience.